Thank you everybody for joining us. I was asked to talk to you today about disparities in cancer care, and I am honored to do so. Our objectives today include to understand some key concepts in disparities in cancer care, to identify major factors that contribute to disparities in cancer care, and perhaps to identify some strategies that we can all adopt to address these disparities. Now, my expertise on today's topic does not come, I'm afraid, from extensive research or publications. It comes from really a 10-year accumulation of experiences in my clinical practice as a community oncologist at Denver Health. As many of you may know, Denver Health is the primary safety net institution of Denver County. And even though we are not a public hospital, as many people assume we are, we still very proudly hold as a core mission to provide care for everyone in our community, regardless of their ability to pay. So my street cred to give this talk to you today is my experience taking care of urban poor cancer patients. I would love to hear, perhaps in the breakout session, from others that can bring in the perspective of disparities that are unique to rural areas, for example. That's something that I'm just not familiar with. I actually had given this talk several years back, perhaps 4 or 5 years ago, and sometime last year I agreed to give it again. And I mistakenly thought back then that it was not going to be a big commitment or a big deal to do it because I would just be updating my slides with the latest data, the latest research, but I was terribly wrong. The social unrest of 2020, and specifically how the Black Lives Matter movement peaked last spring, has fundamentally changed this conversation. And I found that the slides that I had before were empty and meaningless. I found that the message that I was trying to convey was not even there. So even though I'm still a little unsatisfied with the end product from today, at least I hope that we can start a conversation. So we can start with some definitions. Health equity is the ideal state, and it is when people, regardless of who you are, where you live, you can have the opportunity to live the longest and the highest quality of life possible. Unfortunately, that's not the reality, and what we have really are health disparities, which are the differences in the incidence, prevalence, mortality, survival, and burden of disease within any population. For cancer specifically, even if this disease affects anybody, due to social, environmental, and economic disadvantages, certain groups bear a disproportionate burden compared to other groups. How we define these groups can be whatever we want. It could be age, gender identity, socioeconomic status, geography, such as urban versus rural, and others. Today's focus will be primarily on, but not limited to, race and ethnicity. Since we're in definitions, what is race? And I think that is a key concept that I'm hoping you will leave with today. Race is not a biologic category driven by genetic factors. Race is actually a social construct. It is based on some physical characteristics, such as the color of your skin, the shape of your eyes, but it is a social construct. And ethnicity are the common heritage shared by a particular group. This is a screenshot from the National Cancer Institute's website on the topic of disparities in cancer care that was, up there several years ago. The top row in purple shows us concrete examples of how certain racial and ethnic groups are disproportionately affected by certain types of cancer. And the bottom row with circles lists the reasons why that might be so. So we know, for example, that African American women tend to have a more aggressive type of breast cancer and are much more likely to die from it compared to white women. We also know that the highest rates of kidney cancer cases and death occur among American Indian and Alaska Natives. Liver cancer, for example, seems to disproportionately affect American Indian and Asians. And African American men are more than twice as likely as white men to die from prostate cancer. And there are other examples as well. The danger here when we start learning about these disparities is to start looking again as race being a genetic-based construct that are what is driving these disparities. And nothing is further from the truth. And the truth is that it's really all the other factors, including healthcare access, socioeconomic factors, exposures, diet, physical activity, all are contributing to these disparities. And the major omission in this slide is structural racism being a huge factor contributing to healthcare disparities. In more concrete numbers, I'm showing you here some statistics. So these are coming from the SEER database. If we separate by race and ethnicity, we see that Black men and women will have the highest rate of new cancer diagnoses, shown in the light blue, as well as the highest death rates, and that's shown in the dark blue. The good news is that over time, we're starting to see a narrowing of the gap. So we see this predominantly driven in lung cancer cases because of the smoking cessation efforts. However, even though things are getting better, the differences still persist until today. If we break them down by common cancer types, such as prostate in the upper left, breast cancer in the upper right, and colorectal cancer in the bottom row, the storyline is still the same. Black patients are dying at a higher rate than other race and ethnicities. What if we break things down by a different category that is not race specific? Is this story all that different? It may seem like it, but deep down it really is not. This slide shows us that if you live in an area characterized by higher income, and that's represented by the dark blue dots, your 5-year survival rate for a cancer diagnosis is much better than if you lived in a poor neighborhood, and those are represented by the orange dots. Now, what does living in a good neighborhood mean? It means that I was, first of all, able to secure probably a mortgage and actually buy a house in such a neighborhood, a privilege that was not granted to many for so long due to redlining, and that is a whole topic in and of itself. And that's an example of structural racism. It also means that I probably have a job that gives me health insurance benefits. It means that the local hospital might be a comprehensive cancer center with a fellowship-trained breast radiologist interpreting my mammogram, for example. It means that the water that I'm drinking is probably not polluted by carcinogens and that I can buy fruits and vegetables at the nearby store, and that I was taught by my parents to, focus on eating things that are more than just boxed mac and cheese. This is another way to look at the same problem. How about disparities based on your insurance? In this slide, we see colorectal cancer prognosis based on insurance. Private insurance is in the continuous line, and uninsured or Medicaid are in the dotted line, and each color represents a stage. Red is stage 1, blue stage 2, green stage 3, and yellow stage 4. If we look at the superimposing lines highlighted by the green arrow on the right, you will notice that the insured stage 3 colon cancer patients have the exact same survival than the Medicaid/uninsured stage 2 colon cancer patients. So as you have seen, disparities exist in many different contexts depending on how you separate the group. We looked at where you live, what insurance you have, your race. However, the disparities based on race and ethnicity are just simply more pronounced and compounded on top of each other. And this is because racial and ethnic minorities are more likely to be poor, are more likely to live in disadvantaged neighborhoods, are more likely to be in poorer health, be uninsured, have less education, more obesity, less physical activities, and in general have more barriers to access to care. But more importantly, and certainly most difficult to measure, is the fact that racial and ethnic minorities are discriminated against, and they suffer from overt aggressions and constant microaggressions that undermine their health and healthcare. Let me circle back to the slide from the NIH from a few years back. And to their credit, this infographic is no longer there. It is critical for all of us today to break free from the racialized conceptions of susceptibility to disease that persist to this day. The worst outcome that we see in Black, American Indian, and other racial and ethnic minorities do not come primarily from intrinsic biologic or genetic differences. It comes mainly from bias, prejudice, and stereotyping by those of us in the healthcare community. I found the best examples of racism in medicine in social media, though these instances are showing up in the news as well. To the left is a tweet from Dr. Coleman. She is a fabulous trauma surgeon here at Denver Health. Her husband is a former NFL pro football player who is also African American. And he was, I think several months ago, was out of state. He was not here in Colorado, and he got into a car accident and was taken to a local level 2 trauma center. So they called Dr. Coleman as his wife to let her know what was going on, and that her husband, thankfully, was safe and was being discharged. But little did they know that Dr. Coleman, as a fellowship trained trauma surgeon, knew exactly what kind of evaluation they should have offered to her husband, of which he got none. She raised up a storm and was able to get him the care he needed. The question is, how many other patients don't get what they need because they don't have an advocate like her? And so in this tweet from the left, it reminds us that racism in medicine means fewer diagnostic tests, incomplete evaluations, shorter hospital stays, inappropriate discharges, and fewer pain medications. And that happens all the time. Not too long ago either, a Black female physician died from COVID, but not after sharing on her Facebook page how she was being mistreated. And this was published on the New York Times. These are two quite flagrant examples involving highly educated, adequately insured, and not poor Black patients. So can you imagine what is going on with those who do not have an advanced degree, are uninsured or poor? How many come to our emergency rooms or to their primary doctors and complain of symptoms and don't get the necessary workup and delay their diagnosis? These biases are real, and they're certainly scary. How many don't even bother to seek medical attention out of mistrust of a system that has failed them once and again? I also like this graphic, even though it is old. It reminds me that for many of my patients, their cancer is the least of their problems. How much harder it is to go through the cancer journey when you don't know where you're going to sleep tonight, when you don't know where your next meal is coming from. And an added layer also missing in this old graphic is when you have to fight against racism. Racism, however, is not simply private prejudices or biases held by individuals. I think that pretty much most folks in healthcare really strive to check those biases. But racism is also actually produced by the laws, the rules, practices that are sanctioned and even implemented by various levels of government, like it says here on this slide, embedded in the economic system as well as in cultural and societal norms. And I'll talk a little bit more about this. Here's an example of structural racism within medicine, and this fascinating article was published in the New England Journal of Medicine in August of 2020, and it compiled a list of clinical algorithms that we use every day in clinical practice. And it had examples from all specialties identifying them as being racist. Here I highlight from this article those that pertain to oncology. And these tools have race as a variable. And again, coming back to the mistaken concept of race as a genetic attribute affecting outcomes. The equity concern in all of these examples is that by inputting Black race, patients are getting less care than their white counterparts. So I would encourage you, if you get a chance, to review this reference, as it is a quite interesting read. With all of that said, we can dig deeper into this topic. This oncology health disparities model was proposed about 15 years ago by Dr. Polite and was published in the JCO. At the center of the model is a question: why is one group of patients dying from cancer at a higher rate than another? And again, grouped identified by race, socioeconomic status, gender identity, for example. And the three components contributing to the answer are: first, do we have groups that are diagnosed at a higher rate or at a more advanced stage than others? Yes. The second one is, once diagnosed, are they being treated differently? And third, once treated, are they benefiting from treatment in the same way or not? And we can bring this model to life, and I just decided to pick colon cancer as an example. Once again, here, see that Black men and women are dying from colon cancer at a higher rate than others. And we can tackle that first question. Are African American and other ethnic minorities being diagnosed at a higher incidence or at a more advanced stage? And the answer is most certainly yes. And it turns out that when quantified, this top section contributes to about 2/3 of the disparities. Early colon cancer diagnosis can be successfully achieved via screening colonoscopies, and that intervention alone can reduce mortality by 50%. Unfortunately, not every group of people will get screening at the same rate. African American and Hispanics, for example, are less likely to get screened. Spanish-speaking Hispanics are also less likely to get screened compared to English-speaking ones. So what are the stories that I hear all the time in my clinic? Things like, I never had a primary doctor, or I wanted to see a doctor, I didn't have insurance, or no one told me I needed a colonoscopy, or I've been having abdominal pain, or some problems in my bowel movements, but no one would listen to me, or no one asked me about my family history. And turns out that that person had pretty extensive colon cancer history in the family, and then didn't get the colonoscopy recommendations that were appropriate, or they couldn't afford the procedure, or they can't take time off of work. Or the other thing, when you get a colonoscopy, typically you're required to have someone drive you back home because you get sedation. And so if you don't have anybody to drive you back home, then you don't get the procedure. So that's another big excuse. Some people are just scared of what they would find. I remember very sadly about a patient who just was so scared of it because it reminded her of some childhood abuse trauma. And so she just was avoiding it, and then ultimately got diagnosed with a very advanced stage colon cancer. There is a good reason to believe that there might be a component of different tumor biology and genetics that are affecting this group, but it is not the main driver for sure. The question is how much of the difference in biology actually is related to these lifestyle and environmental factors that are listed here. And once a patient is diagnosed with colon cancer, then we also see differences in the treatment that they receive. And data shows that African Americans are less likely to receive standard surgeries or chemos. Medicaid and uninsured are more than twice as likely not to receive adjuvant chemotherapy for stage 3 colon cancer, for example, and other problems that contribute to an inadequate receipt of treatment. And really, the bottom line is that what we see is a lot of inadequate access to healthcare. There's other stuff as well, medical comorbidities, mistrust of a system that continually fails them. The most frequent story that I get to hear in my clinic is an uninsured patient or even someone with Medicaid who recently got a colon cancer emergently resected, but was never able to see medical oncology for adjuvant chemotherapy because they went to a local hospital and they were told that they don't take Medicaid, or perhaps that as a Medicaid patient, your first availability to see a Medicaid patient was several months away. I mean, essentially negating them the benefit of adjuvant chemotherapy and placing them at higher risk of recurrence and death. And then I'll see them with metastatic disease. I mean, we can't really blame individuals about this problem, though. I can't blame the scheduler person or the nurse navigator who is triaging this. I think that the system, in fact, is that the system is inherently biased against poor people. Any practice that takes care of Medicaid patients, we know will lose money doing so. So this is, just another example of structural bias and racism. On the flip side, we see good stories too. There is a particular patient that I remember well. I had many years ago. He had completely decompensated schizophrenia with paranoid delusions, and he had locally advanced rectal cancer. So I remember discussing at tumor board, how on earth are we going to pull off standard of care, which was neoadjuvant chemoradiation, resection, and adjuvant chemotherapy, which was what was done back then. And I remember with the surgeons talking, maybe we should just go ahead and resect it and forget about all that stuff. But I was, still proud of the team that said, what, let's give it a try. Let's go that extra mile and give this patient standard of care despite all of the challenges and the comorbidities and the schizophrenia. And it was certainly not easy. And this was done by our team at Denver Health that is stretched out thin with the least amount of resources. Yet I'm always impressed how time and again, the team is able to rise to the occasion, and this patient was able to get standard of care treatment despite the odds. We were able to connect him to the necessary mental health services, and he got treated and cured. I actually discharged him from my clinic after 5 years of surveillance. While we may not always succeed, it is never because of lack of trying. Once a patient is on treatment, do some benefit differently, or is the quality of the treatment different? Are they tolerated differently? And another example that I can share, for example, today, that pertains to this topic. Many of you know that the way we indirectly measure renal function is by getting a creatinine level. And this is a key piece of information, since it will tell us whether someone's kidney is working well enough to use a particular drug like cisplatin, or what dose to use. Turns out that this calculation is inherently racist and apparently not based on biology. The MDRD equation will artificially give better kidney function for the same creatinine level in blacks compared to whites. So the artificially elevated value of kidney function may delay referrals to specialist care or a kidney transplant. In oncology specifically, it can directly affect chemo dosing and potentially giving more toxic doses to African American patients. So almost a year ago, last spring, amid the Black Lives Matter movement, and thanks to the very hard work and internal conversations within Denver Health, the race correction for renal function was eliminated from our lab reporting. And, why is it as part of this slide in particular? Then what it means is that getting rid of this structural racist bias in something as simple as a lab calculation will allow our patients to get a more appropriate non-toxic dosing of chemotherapy, such that they're able to complete their treatment and are able to tolerate it better. And that's why I brought it up. So you mentioned before the racial disparities in cancer seem to be decreasing. However, there's also concern that things may soon be getting worse. And this is because right now, while oncology is seeing incredible scientific advances, these are not happening for all of our patients. There is a lag in implementation of medical advances. After all, 55% of Americans get their cancer care at their local community oncology practice that is not affiliated to a big hospital, academic, or medical teaching institution. A lot of these advances have to do with genomic medicine. There is a disparate implementation of genetic testing. So for example, when I order genetic testing or mutation stuff in our tumors, Medicaid does not cover it. Those tests get canceled much more frequently compared to private insurances. And the problem is that the implications for disparities in access to genomic medicine impact not just the patient, but also the whole family and generations into the future. An undiagnosed Lynch syndrome, for example, or someone with a BRCA mutation in a patient, it doesn't just affect that patient. It implications for the rest of the family, and that they're not getting, the necessary care for early screening and prevention strategies are not there. And so that's devastating. So how do we move forward with these enormous problems? So first of all, we start with what we're doing today. We learn more about it. We become aware that it is indeed a problem in some shape or form, and it does affect everyone. But how do we move forward past that awareness part, and how do we actually fix this? And that is the most challenging part for sure. At the personal level, I think you will hear very frequently in our clinic bullpen, like, if this were your family member, what would you do? If this were the Queen of England, what would you do for this particular patient? And how can we go that extra mile for this patient to get them what they need? And I believe in my heart that everyone in oncology strives for this in whichever role they play. But real and lasting change will require institutional, regional, and national policy change, and those are much harder to make happen. If we do achieve those changes, it will also require ongoing vigilance to make sure that we don't go backwards. So if we return to this health disparities model, the proposed path forward starts with access to quality healthcare. And by access, I mean, how do we make healthcare accessible and acceptable to those who currently do not have access to it? I also mean, how do we make good food, clean water, clean air accessible to those who don't have it? So how do we improve access? Perhaps you can ask yourself, is it true that my institution cannot do charity work? Is it true that my institution cannot take a Medicaid patient, or they just don't want to? And typically the answer is they just don't want to. Is it true that my company makes it extremely hard for certain populations to access their patient assistance programs, for example, or their grant applications, for example? What policies that are currently in place, in fact, are part of structural racism, and can we change them? Ultimately, in my mind, the bigger question is healthcare a right or a privilege? And it's like, why do we seem to talk all the time about healthcare being a right when the system is clearly built for it to be a privilege? Maybe we just need to be comfortable with living in a world of health as a privilege. And where is this moral dilemma coming from? I think no one is comfortable with health being a privilege. So, these are difficult, uncomfortable questions, and would require probably politicians and advocacy to answer those. But that's what it's in the end the problem. I think also that the scariest part of it all is how close we all are to being part of the have-nots. All it takes, you all know this, is a cancer diagnosis for you to lose your employment, lose your health insurance, eat up all your savings, because we know cancer care is very expensive, and be in the need of Medicaid, only to realize that you don't have the same access to healthcare anymore. And I see it every single day. The second part of the path forward, the one that addresses the disparities found in the receipt of treatment, is to provide culturally competent care. That is what true personalized cancer care is. We're not just going to match the best drug for the specific tumor molecular profile. More importantly, culturally competent care and personalized care is to identify all the needs of the person receiving cancer care and matching these with the appropriate resources. Within the continuum of cultural competency, the majority of us live in cultural blindness, where we do our best to treat everyone with the same excellent care. While this is not inherently wrong, unfortunately, it's not enough. We all need to strive to move further up in our cultural competency, and this is achieved by looking hard for individual and cultural differences, engaging stakeholders from diverse groups to hire culturally unbiased staff, to train them, and to implement changes to improve services based on the needs. And finally, if the third component in health disparities model is the benefit of treatment, the way to overcome this is through research. It is imperative to include underserved patient populations into clinical trials so we can understand differences in tumor biology, benefit, and tolerance to treatment. After all, it is widely known that current clinical trials do not represent real-world patients. For example, clinical trial participants tend to be young and white, which is not what the real-world patient population is. So how do we know that those results are applicable to our patients? Currently, less than 2% of cancer patients enroll in therapeutic trials, and the most important barrier being that they're not offered wherever they are getting their treatments. Other reasons are also listed here. Finally, one last thing, as I read through the literature in preparation for this presentation, I was struck by the similarities between the proposed solutions to address disparities, as well as the proposed solutions to address inefficiencies of cancer care. And whatever we have ongoing right now is simply not sustainable, morally or economically. As we have learned during this pandemic, healthcare resources are indeed a finite resource, and we will drive ourselves to the ground by going on about business as usual without any meaningful change. And I will leave you with this slide showing what real equity is, where we have to give more support to those who need it the most. And that's my part.
Hi, my name is Meg. I'm the social worker at Denver Health in the Oncology Clinic, and I wanted to thank Dr. Okuyama for that wonderful presentation that is pretty enlightening. I've been working at Denver Health for about 3.5 years in the Oncology Clinic. Previous to that, I worked in hospice and home-based palliative care for about 13 years. We saw patients from all socioeconomic backgrounds, but previous to this position, I had never worked with any patients that were homeless or who were non-citizens. So this has been a learning experience for me, and also a very humbling experience for me as I see people and what they've gone through and what they continue to go through, and how resilient they are, and also how they still remain hopeful and grateful for everything that they have. So what I'm going to do today is go through some of the things that we can do on an individual level as we meet with patients. And I thought I would start with this definition of social determinants of health. So I won't read the whole thing, but they are the economic and social conditions that influence individual and group differences in health status, including one's living and working conditions, distribution of income, wealth, influence, and power, rather than individual risk factors. So they're often shaped by public policies and reflect prevailing political ideologies. And this talks about how they can be very damaging. And like Dr. Okuyama said, we need to do things really structurally and globally to get rid of racism and other inequities. I'm going to talk a little bit about the challenges that many of our Denver Health patients face. A lot of them are working in lower paying jobs, service industry jobs, and they've been especially affected this past year by COVID. Transportation for our patients is often a barrier. They don't own cars or can't drive. They don't have the money for bus or Lyft, especially when they have to come back numerous times for tests and appointments. Sometimes they're raising grandchildren or helping with other family members, which puts even further financial and physical burden on them. Their literacy levels and lack of education is a big barrier. They can't navigate applications. A lot of times they don't have access to internet or computers for applying for benefits, or they don't know how, and they get very discouraged from trying. This reminds me of one patient I met with who had to stop working because of going through treatment and how his cancer was affecting him. And so we applied for some grants, and I told him that he should consider applying for Social Security disability. So he took all the information, and the next time I met with him, and he was bringing me paperwork to look at, he showed me that he had already been awarded Social Security disability, and he didn't even realize that. So it can be very overwhelming for our patients. Other issues that they run into is food insecurity. They have no access to nourishing food and no ability to prepare it. And loss of income due to cancer and treatment, and no savings. As Dr. Okuyama mentioned, these co-payments and for doctor visits and treatment can deplete any savings that they have, which often isn't very much to begin with. So we try and hook up patients with whatever resources they are going to qualify for. So the cancer grants from foundations, which can give them some money to live on, is usually specific to the type of cancer. So they can only apply for the ones that they qualify based on that. Their working history determines eligibility for Social Security disability, Social Security retirement benefits, utility help, and some cancer grants. Sometimes they have to be working to receive money from cancer grants, working at the time of diagnosis. Their legal status, criminal history, and credit score can all determine eligibility for housing and utility help. Ages of the children in the household can determine what kind of help is available to them. Age of patient can determine housing and qualification for other resources like transportation help. Insurance can determine what treatment they can receive, transportation options, if they can get help at home for non-skilled needs. And housing can determine what treatment a patient can endure. So I'm going to talk a little bit about what can be done by staff in their one-on-one interactions, like I mentioned, and a few things that can be done in your clinics for the LGBTQ population, if possible. First, I'm going to talk about some of the universal strategies that can be used with all patients, and then I will talk specifically about the populations listed on this slide. So some of the universal strategies are practicing cultural humility. Realize that you bring your own cultural differences and biases to the relationship with patients, and that this acknowledgement is part of a lifelong self-reflection. Realize that cultural competence is not an endpoint. It is a process that can never really reach an end. We always can learn and grow. Don't rely on cultural generalizations or stereotypes. Check in with patients about their individual experiences and cultures. Realize that some patients who have been marginalized don't think that cancer is the worst thing to ever happen to them. And that statement really blows me away. I think most people, when they hear that they have a cancer diagnosis, is, probably the worst thing that you can imagine hearing. And yet for these patients, it's just one thing in a long list of adversities. Don't assume literacy and functioning levels. Ask about support systems and resources. Look for strengths, including resilience, support systems, faith, and comment on them. This can really build a patient up. I don't think enough of us ever talk with others about the good that we see in them and the strengths that we see in them. Refer to a social worker for a more in-depth assessment. And here at Denver Health, we do try to evaluate for the social determinants of health when we meet with patients, especially our most vulnerable. Universal strategies, and excuse my typo, I thought I corrected that. Speak in plain and simple terms and avoid medical jargon. Ask questions to elicit a patient's understanding of their diagnosis and treatment options. Ask about important decision makers and patients' families that need to be involved. Ask what you need to know about a patient's culture, family, and community to provide the best help and support possible. You can ask, what do I need to know about you so that I can provide the best possible care to you? Listening to the patient's concerns and following through with what you say you will do will go a long way in building trust. if the patient feels that you are doing all that you can for them, this can translate into them feeling respect and compassion from you. The first group I'm going to talk about are African Americans. The historical experience of African Americans in our country has been shaped by many things, including the things listed here. And it's no wonder that they have a mistrust of the medical community. And realizing what they have gone through, appreciating that, I think helps us to have a little more compassion and empathy, and realize that a lot of times we talk about a patient being non-compliant, but seeing it from another point of view helps us to understand that maybe there's a reason that there isn't trust. Also realize that this population can be born in the US, or they can be refugees and immigrants, and each group differs in terms of their heritage, language, culture, and health beliefs and health practices. I think the suggestions of the universal strategies that we just discussed can go a long way with the African American population, especially following through with what you say you are going to do. Refugees, asylum seekers, and undocumented. And this group, when I work with them, some of the stories I hear just makes my blood boil. I just met with a patient recently who has worked for a fast food chain for 18 years. And he was able to start doing this because it was so long ago. But now he has cancer and he has no benefits from that fast food chain to help with short-term disability or any kind of help. So a lot of them are working without benefits that might help them while they're going through treatment or post-treatment. They won't ever be collecting Social Security benefits, even though they've paid into the system. And I think a lot of them don't realize this as they are working all these years, that there is no safety net for them. Some cancer grants that give money to cover living expenses do not help with those who are undocumented. Or if they do, the patient is afraid to apply for them. I actually just took this out of the slide that didn't get translated to this, but public charge, and I have the definition down there, has just been done away with by the Biden administration. So we're all very happy about that, where they were afraid to apply because they would either not qualify for benefits in the future, or I shouldn't say qualify for benefits, but they would not be able to work towards citizenship or legal status if they had taken advantage of any economic help. So as of a couple of days ago, that is no longer a rule. Aside from that, a lot of times they are afraid of getting their boss or their landlord in trouble if they have to list either one of those, who they pay rent to or who their employer is. And then often they are experiencing PTSD from their experience that led them to flee or got them to the US, along with multiple other stressors. Just some things to keep in mind is that their country of origin, legal status, and level of acculturation have a big impact on the patient and the family worldviews about cancer and other things. one of the things I learned also is that because a lot of them feel that everything is in God's hands, that this might make them feel that it's not really critical to keep appointments. They feel like things are going to turn out like they're going to turn out regardless. So that was kind of an eye-opener for me. And because there are populations from so many areas, we need to let them self-identify what their ethnicity and race are and not assume. You can always tell them if you're working with one of them that has questions about financial help, that the social worker can advise them whether or not asking for help will jeopardize their presence in the US, or we can try and refer them to a resource who can. I'm going to talk a little bit about people who are homeless. So I think a lot of you probably already know that if you're homeless, it's really hard to manage side effects from the treatment or the pain from the treatment. Like some of our other patients, they often can't get needed paperwork together to apply for benefits. So it's kind of a vicious cycle. They can't get adequate rest. If they put a blanket over them in Denver at night, then they can be arrested for camping out. And then if they are not staying in a shelter, they often have to stay awake at night for fear of getting assaulted, and then try to sleep during the day. And I would encourage you not to refer to this population as homeless, because that's not all they are. Refer to them as patients who are experiencing homelessness, because this is only one part of them. American Indians and Alaska Natives, as with African Americans, recognize that they have historically had a lot of traumatic events in their population. Understand that their relational way of being is very important to them, not only with other people, but with all things. They may want to combine traditional and allopathic healing approaches. I think it's good to have a conversation about this so that you can honor that, but also talk about ways that might be detrimental with regular medicine that their provider is giving them. And then also they do have spiritual beliefs and practices that need to be honored, especially at end of life. The LGBT community, they have often been forced or faced insensitive, uninformed providers who have not recognized the discrimination they face on many levels. One thing to keep in mind is coming out is not a one-time thing. It's a decision that they have to make continuously with everybody they meet. And I've put some information about the difference between transsexual, transgendered, lesbian, gay, bisexual, because a lot of times these things get confused. There are issues, of course, when a transsexual person needs to be treated for a cancer, for a part of them that they no longer identify with. It can be very traumatizing, and it can force them to have to come out to the medical team. These are also some things that hopefully you'll be getting a copy of this. You can use to help in building a relationship. And then some things that in a perfect world we could change as far as clinics, having a unisex single bathroom, and also some of our forms and brochures, being sensitive to how those are worded. Did just want to encourage you to attend the next non-CME CE presentation. You will be getting a gift card for that.